So welcome everybody to the webinar tonight, our second of 5 webinars for Brain Tumor Awareness Month. My name is Jim Evans, and I'm the chief of the Brain Tumor program, the Brain Tumor division here at Jefferson, and I'm joined by my close colleague and friend Chris Farrell. Chris and I run the cranial-based effort, pituitary and cranial-based effort at Jefferson together, and we've done so for many, many years. And we're going to share with you a little bit tonight about our experience with quote unquote benign, I'm going to share my screen here, quote unquote benign tumors. Can you guys see, you see that okay, Chris?
Yep, I can see it.
Okay. And so we're going to share our experience with benign. I put quotes on this because these are tumors that are considered benign histologically, meaning under a microscope, et cetera, and often by behavior, but because of their locations along the cranial base and tricky areas to reach, et cetera, can pose their own difficulties and challenges, and we'll share some of that with you. And Chris, would you like to say a couple of words before we start?
Yeah, welcome everybody. Thank you all for attending this. We're going to try to get through a lot of stuff today. There's so many different types of tumors in the brain, but we'll focus sort of on the ones that we most commonly see and sort of try to give you what's things you need to know about those tumors, as well as what's exciting about the future and some of the stuff we've done here at Jefferson's. Thanks for joining.
Okay, so we'll kind of move on. This is our university. This is a cranial-based center that Chris and I run, minimally invasive cranial-based center in our logo. And this is what we thought we'd go over tonight. There's a fair amount of information. We're hoping you guys will be able to ask questions. We already got some online. You can put them in the chat. I think you'll be able to actually ask questions directly. We're happy to go at whatever pace. We can make this as informal as possible. And we're happy to stop and answer questions along the way if need be. But the topics we thought we'd go over tonight are pituitary tumors, meningiomas, and acoustic neuromas. And we'll see how far down the list we get and that sort of thing. Like I said, we'll take our time. But just as way of sort of glossary of terms, pituitary tumors are also known as pituitary adenomas. Adenoma implies a benign tumor as opposed to the term adenocarcinoma. So these are mostly benign tumors. It has another name much more recently called a pit and net. If you hear that, if you're looking online or that sort of thing, I won't get into that right now because there's some discussion whether that name will stick. But classically known as pituitary tumors or pituitary adenomas. The term microadenoma, micro meaning small, means less than 1 centimeter. The term macroadenoma implies greater than 1 centimeter. Just so you'll know as we go through, because we use these very interchangeably. Secretory is the same as functional. What this means is a tumor cell that makes a particular hormone. So it'll secrete something, a pituitary cell. Non-secretory means one that is not secreting or not making a hormone, also known as non-functional. So we'll slip and we'll use these terms back and forth quite a bit because they are interchangeable. So you'll have some sense as a sort of little dictionary of terms here. So by way of introduction, pituitary tumors are very common. They're most frequently benign tumors, usually slow growing. Many are asymptomatic or found meaning by an accident. Someone has a headache or bump on the head or gets a scan. Some may never require treatment, and they can often be cured by surgery. So what's the problem? It sounds like this is a pretty straightforward or simple issue. Prevalence is a big issue. 1 out of every 5 or 6 people have a pituitary tumor. So if you cross 10 people walking down the street, probably 2 of them, at least, are carrying a pituitary tumor of some sort. That means up to 15 to 20% of the population. There's over 10,000 newly diagnosed pituitary tumors in the US annually. So it's a lot. So again, here we are with non-secretory and secretory pituitary adenomas. So we'll start by going over the non-secretory tumors, macroadenomas. These are those that do not secrete an active hormone. They can grow quite large before detection. Therefore, the term macroadenoma, so slowly growing and getting bigger, undetected until they get quite large. They typically will cause symptoms by compression of something, some structure around it. And typically we'll see vision loss by compression of the optic chiasm or hormone dysfunction by compression of the pituitary gland. If you can see this little diagram up here, it's partly obstructed on my view, but this little diagram This little breakout area, this little smaller area next to it shows the pituitary gland. It's encased in a little cella, little saddle of bone. And as it expands, the tumor can push on the normal gland and cause hormone dysfunction. And then just above it is the optic chiasm of the vision system. So as it grows, it can compress on the optic chiasm or optic nerves and cause a classic vision loss. So those symptoms we'll see. So macroadenomas, often and most often treated with surgery. Today we use an endoscopic approach to access pituitary macroadenomas. And often we'll use both nares. This is a picture of a large tumor. You can see eyes on either side, nose in the middle. And we would have an endoscope or instruments going in both sides. They're called binaural. We can also use various angled endoscopes to look left, right, up, and down to get various perspective on the cranial base and on the tumor, as you can see in these panels below. Angled endoscopes allow us to work across and see out to areas that classically with a microscope or looking in historically, even with the naked eye 100 years ago, you could just see down the midline. But visualization with angled endoscopes and new instrumentation allows us to work out to these areas of tumor that are out behind the carotid artery involving the cavernous sinus. And so it gives us drastically better access. We have specialized suites for doing this, and endoscopic operating room suites, where you can see two people working here with a number of different screens and a lot of heads up. And basically, it's almost like playing a video game where your instruments are working here, but you're looking up at a screen, much like you might hold a controller, but you look up at a screen to see what's going on in the game. And there's a few of us working together on this particular tumor. You can see I can look across to this bank of screens, and he can look across here, and it's very ergonomic. We don't twist our head all around, and that sort of thing. You can work very comfortably in this tiny little space, all working together. If you look at this cartoon up on the side here, there's an endoscope looking into this illustration's nose and looking at the cella. So it's the sphenoid sinus and then the pituitary cella. And this is the view with that endoscope looking at it. This is the view you might get. And this is the dura. So the bone is opened up here. The dura, the case around the brain, is opened up. And here's the tumor being dissected away, taken out bit by bit, until we get to this point where this is the diaphragm. It separates the spinal fluid and the optic chiasm and all the structures above that need to be decompressed. It separates them from the tumor down below. When and if this is opened, we can see spinal fluid leakage. And so this is the diaphragm kind of decompressing. You'll see what that's important in a minute. And this is a picture in surgery of the same kind of thing. If you look at this, on this side, the left side of this panel, this is a pituitary adenoma, macroadenoma. The cella is that small bony area. It's all expanded because of this tumor has grown quite a bit. It's pushing up on the optic chiasm. You can barely make out here. There's a little upside down U of gray because the tumor grew up and pushed on it. And then the rest of the gland is being compressed and could be dysfunctional as well in this given patient. If you look at the post-op images on the opposite side, you'll see that this mass is now removed. It's a nice removal. You can now see the optic chiasm completely decompressed, where it was being kind of pushed up like a fist up into it when the tumor is in place. You can see now it's all decompressed. You see the pituitary infundibulum. That's the stalk that connects the gland. Now you can make out the normal gland, which is all pushed off to the one side in this patient where you really couldn't see it on the pre-op. We can see that diaphragm I mentioned. When that comes down, we know we're decompressed. The structures up above no longer have tumor pressing against them, and the diaphragm will kind of settle back where it belongs. And the spinal fluid's above the cavity where the pituitary gland sits is down below. And again, this is if this gets breached, there'll be a spinal fluid leak, and some of you may have known about that. By often putting in a little collagen graft on the inside, and then we put some biological glue along the outside here to seal it. And so that's now going to be, a wall seal, and that's how that would be repaired. And that's what it might look like in surgery. It actually does look blue. And this glue is pretty impressive. It's a biological glue that'll hydrolyze or break down to water and just kind of go away after 4 to 6 weeks. And so your body just does the healing. This holds in the meantime. And you can see a very large pituitary macroadenoma here, by a big obelisk type thing going way up into the brain. And again, we're coming out from the very bottom here. And you can see post-operatively a nice removal of even that huge invasive tumor with the normal pituitary stalk and the compressed above. We've studied these topics quite a bit. We'll of our research, but this is a paper we had done looking at these large, giant invasive tumors, those that are over 4 centimeters and invading all around to different compartments. Our outcomes were excellent even for these large complex tumors, and the side effects were very, very low. And so we can achieve even good removal of these complex tumors. So we'll switch gears. Chris, any comments about the non-secretory tumors or anything I might have not stressed,
No, I mean, I think one thing that just struck me as you were presenting this is, a lot of people will ask me, why'd you go into brain surgery? And one of the reasons is that we get better at this every year. What you just described, none of that did I do 13 years ago when I finished my neurosurgery training. All of this stuff is stuff that's been totally, we operate on pituitary tumors, but never like we do now. So it is such an exciting field, and every day we're trying to get better.
Chris, and we've played a big role in that evolution along the way, right? With our techniques and what we train our fellows and our residents, and even some of the equipment we use has really come a long way. Yeah, thanks, Chris. So secretory adenomas. Now, these are the ones that secrete a hormone. So these grow from cells that typically have the machinery to make some hormone, and the makes about 9 different hormones that we know of. I'm sure there are others that we have yet to discover, quite frankly, but makes a number of hormones. And so secretory adenomas, although considered benign, can be really a problem, be really devastating because of the side effects or problems that excess amounts of a particular hormone cause. And I'll show some examples of that. So this not only has this quote-unquote benign tumor growing there, but it's pumping out more and more of a hormone that can cause a lot of injury to the body. These are often found when they're small. So the term now microadenomas, usually tiny little ones. The reason we pick them up early is because they manifest so many symptoms from making way too much of a hormone. And then cure or remission rates are lower than non-functional disease. Even though they're small, we've got to get every single cell out. If there's a single cell somewhere tucked in the normal gland or tucked in some structure nearby, patients won't go into remission. Or they may go into remission and then have a recurrence. And we've got to be ready to manage that as well. So this is a lifelong commitment doing this. And secretory tumors are certainly that. So this is an example of a secretory adenoma or microadenoma. You can see here, so this is the normal vision system. This is the normal pituitary stalk that connects this gland to the brain, carotid arteries on either side. This is the gland itself. And this gland's about the size of a little kidney bean. But you'll see there's a tiny little tumor here on one side, this little dark area, probably 3 or 4 millimeter little microadenoma, so less than a centimeter, but devastating in the fact that this one's pumping out a lot of hormone. So the secretory tumors come in a number of flavors, so to speak, what they can secrete. These are the probably more common ones that we see. Prolactin secretion, or something called a prolactinoma, can cause in women loss of the menstrual cycle and breast discharge. And this one is unique because this one we can treat with medication. Maybe all of these someday through our research we'll be able to treat with medication, and I probably foresee that. But right now, this is the one that we have FDA-approved medication for. We have 2 main medications. Some of you may have heard of cabergoline or bromocriptine, also called Parladel, and et cetera. But a medication, nonetheless, is still the standard in the U.S. In some countries, they're still relying on surgery for these because the medications are so difficult to get and they're so expensive. Others are excessive growth hormone secretion, causing something called acromegaly, we'll talk about in a little bit. Too much ACTH, which is one that drives our steroid level to go up. So excessive steroids and something called Cushing's disease or Cushing's syndrome. And then less common TSH secreting, which is thyroid stimulating hormone, which can cause hyperthyroidism. And then there's a couple other syndromes we see, but these are probably the main ones. And we'll go over these: growth hormone excess and ACTH excess. So ACTH causes Cushing's syndrome or Cushing's disease. When it comes from the pituitary gland, we call it Cushing's disease because there's a few other causes. And not only does this cause this kind of a change in this individual with the sort of moon-type faces and this sort of ruddy red complexion, and hirsutism, which is excessive hair growth, and greasiness in the skin, and changes like we can see on the outside, this sort of centripetal or abdominal weight gain with thin arms, but it's the stuff on the inside you don't see that can be more deadly. And so hypertension and heart attacks and strokes and all the problems that are caused by excessive steroid like diabetes and weak bones, osteoporosis, fractures. This can be devastating, can shorten the lifespan, and lead to a big drop in quality of life. A separate situation here with a type of a tumor that makes too much growth hormone. It creates something called acromegaly. Acro implies the limbs, the hands, the feet, or the limbs, and megaly means too big. So if this hormone occurs in a child before the growth plates close, they can get super tall, and they get something called gigantism. And that's when you see people that are, 8 and 10 feet tall and have all the associated problems. More commonly, though, this happens in adults when the growth plates close, so they're not going to grow super tall, but they get all these other changes. You'll see in this old picture from the 1800s, they were looking and recognizing, describing this, even not knowing exactly what was causing it. But you can see this young guy looks pretty normal here, and over time gets these features like this, with this bossed forehead and big jaw and teeth that get all spread out and a big thick tongue and these things you can see that look like acromegaly, large thick fingers and a giant hand and very powerful. And big feet, they'll complain their shoe size is getting larger and larger, or their gloves are getting tighter and tighter. But it's don't see that can be equally or more deadly. Something called dilated cardiomyopathy, because the heart muscle gets so thick it can't pump blood adequately, and often can lead to death. And other things can grow, polyps on the skin tags, things like that, but also in your colon, and can lead to cancers, things like that, to progress. So this can be another problem that can limit the life and the quality of life. Often these are adenomas, and the way we manage these is with surgical removal. It's the mainstay. All tumor you see here will often have a pseudo capsule, like a little capsule around it, and we'll try to take advantage of that and do an extra capsule removal and literally try to remove that tumor on block. Unlike the cartoons I showed you earlier, this, and again looking at the cella, here's the cartoon of the endoscope, sphenoid sinus, and then the cella, same kind of thing we showed before, the dura being open, but this one's different. There'll be a tiny little tumor in here. And we've got to identify that on imaging and then intraoperatively. And again, in a gland that's about the size of a kidney bean. So this tiny little 1 millimeter, 2 millimeter tumor, we've got to dissect and try to remove on block like that. Sometimes we can't find it, and we need to have a very coordinated way. And Chris and I work on this skill regularly to try to be able to identify a tiny little tumor where this little kidney bean shaped gland, we may need to slice into little quadrants and explore each little area of the gland without damaging it or trying to minimize damage to the gland, yet find this little tumor that sometimes is not even perceptible on imaging. And we have other means to detect which side it might be on. And this is a kind of cartoon showing us identifying that little mass. But there's also a chance when we know it happens to be on one side due to other types of testing, blood tests and sampling, that sometimes we need to actually remove that half of the gland. And somewhere in there, they'll find some little 30 or 40 or 50 micron, tiny little fraction of a millimeter tumor. And we'll try to get patients into remission. And it just takes a single cell anywhere else that can prevent that. So adenomas, what's new?
Hey, Jim. Jim,
Please.
just before you go on, we had a couple questions come in.
Great.
One was for these larger tumors that are compressing the optic nerve and the chiasm and causing vision loss. If you take the tumor out, what happens to the vision?
Great question. You want me to field it, Chris, or do you want to give it a shot?
Yeah, you can take that.
So it depends upon it depends on a number of factors. One is how long things have been compressed and to what degree. So we have ways of testing that. So you can test at the bedside. We look at the visual fields, and many of you may have seen us count the fingers and do all these things, but there's more sensitive testing called automated visual field, Humphreys and Goldman perimetry, and different ways of testing with devices. And then even a predictive test called an ocular coherence tomography, or OCT, almost like the abbreviation for October, test that looks at the nerve itself, looks at the nerve fiber layer. And you could argue that each eye has millions of nerves going to, but just say there's like 5 going to each eye. If you've lost 2 or 3 of them, we can decompress till the cows come home. We cannot resurrect new fibers. So there may be some persistent visual loss. We will prevent it from getting worse, but there may be persistent visual loss. And we can determine some of that with this testing, looking at the nerve with OCT and that sort of thing. And then by history and how long it's been. But the favorable thing is when it's not been that long, where some of these nerves may be shut down but not gone, almost like when you sit on your foot too long. and it goes to sleep, and you get off and it tingles a bit and it kind of comes back. Well, these nerves can have that too, and we call that neuropraxia in neurosurgical terms, but basically asleep. And when we decompress, some of those nerve fibers can start firing again, and that vision can open up. And that's what we strive for. Although it's dependent upon how much injury there's been, how long the compression's been there, et cetera, we try to decompress everybody exactly the same, try to get the entire mass out with the hopes that some of those nerves are asleep and they'll kick back into gear. And frequently they do. Frequently we can improve vision if we take them out. So time is important and the degree of compression is important. Does that help, Chris?
Yeah, I think that's, that's perfect. And it's tough sometimes to put a number on or what the likelihood. Fortunately, most patients do get better, but the earlier we pick it up and the less severe the vision loss, the better.
Right.
And I mean, sometimes the goal of the surgery, there are some tumors we can't get every last bit of it out, but if they're losing vision, what we really want to do is get enough of it out that we get the pressure off the vision nerves, and then we can deal with the rest of it another way.
Right.
But we hate to leave the OR without decompressing those nerves. There was an additional question about secretory adenomas, the prolactinoma, which is the one type of tumor we treat with medications. It was, if the prolactin levels come down with medication, does that mean the tumor is shrinking as well?
Go ahead, Chris, you want to field it?
Sure. So, again, these prolactinomas, which are actually really common, fortunately, we can treat those usually with medications, and about 95% of patients will have their prolactin levels come down, and the tumor will also shrink. It's a little variable in how fast the tumor shrinks and how much it does, but most of them do come down. I always want to make sure that we get what's called a biochemical response, meaning the lab numbers come down, and a radiographic and imaging. So we'll often follow with, even though the labs are coming down, we're still going to check some MRIs over time to make sure those are correlating. The tricky part becomes, what if you've lost a lot of vision and you have a prolactinoma? Well, we could shrink that with medicines, but that might take months. Should we go in there and operate to get the vision back? And that's a tricky one. And sometimes we'll do a trial of medications and see how fast you're responding, but that's a very tricky situation. But most of the time, yes, prolactin comes down, tumor's probably shrinking.
Yeah, very receptor dependent. There's at least 5 receptors we know for prolactin in these tumors, and it depends on the combination. That's something that's under study. And why it is that we have, say, 5 different people, and they might all respond a little bit differently. One might be robust, one dose and boom, and one might get doses for months and it's kind of slowly inching its way down. It depends on how efficient those receptors are. We can't always predict that. We will, I think, in the future, with better molecular studies and with better molecular imaging, there'll be a time we'll be able to tell. And then maybe if we have more directed drugs, that'll be very personalized. But like Chris said, we usually start the drug and watch carefully. Often the levels come down, the tumor will shrink down accordingly. And in some people, if they start real small, it can almost be curative in a small percentage of patients. And many times, though, it's a lifelong thing. We get the levels down, get the tumor to shrink down, and then they just have to maintain the drug for, in perpetuity. So I hope that helps a little bit. Any others, Chris? Are you saying something? If you're talking to us, you're on mute.
Question is, you said that surgery usually has low side effects. What have been some of the long-term side effects you've seen over your years of practice?
Okay, so I'd say, first of all, maybe you don't get all the tumor out. You could argue that's sort of a side effect we don't want. But some of the things we can see from pituitary surgery, you can imagine we're working in the gland. It's this tiny little gland. We're showing these big pictures, but we're using instruments in this tumor that look like we're a jewel sauce in surgery. It's a tiny little space to work in, very delicate. So the gland can dysfunction. Sometimes the gland function can go down temporarily. Maybe the water balance function where you drink a lot and get thirsty, or maybe the thyroid level goes down, that sort of thing. So certainly gland. You could argue spinal fluid leakage as well. I showed you that membrane. Sometimes we can get a leak. That's kind of not necessarily a complication, but something we see, maybe a consequence of just working in this area. And we have great ways to control it and seal it and repair it. And so that's become less and less consequential over all the years. And as Chris said, the experience in the past, 5 and 10 and 15 years. So that's much less a problem, I'd say, today. You could argue vision loss, very uncommon. In fact, mostly you can stabilize vision or improve it, as Chris alluded. but vision loss, if there's a lot of compression and the nerves are really at risk, they're kind of on the ropes already. People have almost such profound vision loss that any subtle change, even sometimes a decompression, can lead to some worsened vision. That's not common, fortunately. I'd say those are probably the big ones. Chris, anyone you want to add?
Yeah, no, I think that's a good answer for that. Another question we had was, does having a benign tumor put you at risk for a malignant one like a glioblastoma? I can answer that. Generally, no. They're very different genetically, the way these tumors form. Sometimes brain tumors can be associated with other types of tumors that can be cancerous elsewhere in the body. There are sometimes, especially these pituitary tumors, there's rare syndrome called multiple endocrine neoplasia syndromes, where you can have tumors in other glands. The glioblastomas, which are an aggressive type of cancerous tumor, they can rarely be associated with tumors of the colon or otherwhere, but generally these benign tumors and malignant don't cross over. All right.
And it's also very rare, I just add, that a benign pituitary adenoma, like we've been discussing so far, will take them. There are rare cases when we've seen that. And we don't know if it's some selection of some particular portion of the tumor cells or some clone of cells that's already in there that just eventually continues to grow, or if something actually degenerates. The number we see of malignancies, pituitary adenoma, is exceptionally rare. I've seen 4 in my career so far, and that's a lot compared to what most, and that's, I guess, because we see so much pituitary pathology. It's just we'll by nature pick up a few more than other centers, but that's a lot. Most will go their whole career and see a pituitary carcinoma.
And then final question is, so what's the likelihood of one of these non-secretory macroadenomas coming back? And if it does come back, grows back, how do you treat it?
Do you want to field that, or you want me to go?
Go ahead.
So it's pretty rare. A few factors. It's maybe a lot for this, but how invasive it is, size to some extent, but more so what compartments it goes into. Those that might go around the carotid artery in an area called the cavernous sinus, we have a lesser chance of getting those out, although not as low as it was in the past decades. We venture there and do a lot better too, with better visualization and better instrumentation. But that can limit us. And so it depends upon some of those factors. On rare occasion, they can be different consistencies or can blend with the gland, and it's a little difficult for us to tell when we're looking at it. So we might even be a tiny bit more conservative so we don't damage the gland or some other structure. We might see in a post-op scan there's some residuum that needs to be followed. There are many circumstances when that residuum is devitalized and we watch it for years. I have some people have been in my practice for 10, 15 plus years that were just still following along with some residuum that doesn't grow. Others in a smaller percentage will grow. And if it does return, we have to decide, is it an area we can remove with a good likelihood, and we'll go back to surgery? Or is it something that maybe not, and we may use an adjuvant treatment like focused radiation or stereotactic radiation, and that can very much neutralize and has a very good track record for pituitary tumors. We don't need it often because we're good at taking them out, quite frankly. And that's better than having your gland or your vision radiated if we can reduce that risk. And it's necessary, a very good stereotactic radiation plan can be excellent for control of a tumor like this. Primary, but as a backup plan. Anything I missed, Chris?
Nope, I think we're good.
Okay, so we'll talk just a little bit of what's new. What are we doing at Jefferson to help advance this field? And I've just included a few things here that we've worked on over the years. I actually had a ton in here and I started chopping out because we're very passionate about this. Reconstruction is something we play a very big role with in preserving good sinonasal function. Working through the nose is not entirely benign either. Some people can suffer beyond the first few days from surgery. We want to be very careful with that so that we get good long-term outcomes. Good structure preservation and good function preservation. This simple little repair with Surgicel was something that we started using here and promoted elsewhere as well. And this can work very, very well. We published a paper on this some years ago with a simple, very cost-effective repair. It's very simple to do and showed leak rates that were in the order of 1.1%, which are lower than most centers that are out there to begin with, that will repair with lots of material and lots of tissue from elsewhere in the patient's body, whether the nose or from the abdomen or the thigh. And it's we found a lot of that's really unnecessary. This type of repair I showed a cartoon of earlier. If there's a leak or that sort of thing. We'll put an inlay collagen graft, and we'll cover that with a little bit of biological glue. I showed some of the pictures earlier. We also published on this over the years, and many centers have adopted what we do. This can work very, very well, very low leak rates. Does not require any packing of the nose, which can be super uncomfortable for patients and lead to complications like infection beyond discomfort. And doesn't require grafts from elsewhere. Many pituitary centers will take a fat graft from the abdomen, requiring another incision and additional pain and risk of infection, or tissue from the thigh, and bring that in to kind of seal up the nose. And we kind of showed over the years that it's just really unnecessary. Very low postoperative spinal fluid leak rate, 1.2% in that at that time. And as we go along, Chris and I, these get lower and lower and lower because we keep honing in and getting better at doing it. It's our trainees that maybe can strive for 0%. We had to work on kind of developing some of these techniques and over the time. So whether we can actually ever reach 0% seems not at all possible, but we'll get very warm to that. And I think our trainees will get there. What about the use of straws? This is something that I had a personal vendetta against for many years, because it was always taught all over the country and other countries that if you use a straw after this kind of surgery, you'll make a negative suction in the nose, in the sinuses, and that either suck the repair apart, or you might cause a leak or cause bleeding. And there's all this premise when we were in training, and Chris can attest to this, that if you ever saw a straw in a room, you'd be slaughtered by your attending or by the faculty, because the patients would cause damage. And so it seems like such a strange thing. And I didn't think there's a whole lot of premise for it. So we set out to study it. And we actually did a very controlled study looking at this. And it turns out it's perfectly fine. We paper and part of my vernacular, but the editor encouraged us to use this term, straws don't suck. And actually worked out great. And we have shown that it does not create any negative force. In fact, it's actually beneficial to patients to be able to use a straw, because half the time they're stuffed up in their nose, they might have a little bandage on, and they're trying to drink and they can't keep up and they get dehydrated, especially if they have diabetes insipidus, where they're urinating a lot and getting very thirsty temporarily. This is a big impact that makes a better quality of life for patients. So some simple little thing like that we set out to study and disprove, I would say, probably close to a century of misguidance. We maintain a molecular genetics effort here. We have a certified tumor bank. The CAP is College of American Pathologists. It's a very highly, very strict Q&A kind of maintained tumor bank that allows us to interface with other centers that maintain similar kind of tissue banks, allows us to study DNA and RNA. And in particular, we study RNA expression profile. We're looking at what these tumors like, what makes them tick, and how are they different from one another, because they're all usually glommed into one term, pituitary adenoma, but they're very different from a genetic standpoint. We set out to study invasive and recurrent tumors and things like that. And just by one slide, it's too much to talk on this meeting today, but just looking at these sort of simple resected tumors that just don't recur versus those that are invasive or recurrent, we can see that the genetic profiles of what's upregulated and downregulated are almost complete polar opposites. So where we used to glom these tumors all into one, they're very different. And this may open up new avenues and new genes or pathways that could serve as possible novel treatments in the future. So it's not far off that we may have new things that we can target to treat these tumors. And as I said before, the real nirvana is to maybe have a pill for each one of these things. And we'll sort of put ourselves out of business, but help our patients quite a bit, at least out of the surgical business. But someday that's what we're striving for. Surgical instruments. Chris and I have worked here to develop new minimally invasive endoscopic instruments over the years. And these kind of things we developed here that allow us to facilitate this surgery in a better way, better dissectors, more advanced things like these rotating instruments that help us to work around corners and work in tight spaces that now have been adopted and used all over the country and in other countries. And so this is some of the things we've innovated here. This is a picture of a bipolar that we recently developed that allows us to do cautery in these little tight spaces. And these can be used to other minimally invasive techniques too, not just for pituitary, but other ways we work in the brain and spine. This is a book that Chris and I put out a few years ago, along with two of our fellows or trainees, which I'm proud of all these guys. We worked together and put all of our thoughts together and how we can do the surgery in a better and less invasive way. And then just recently, we were invited to do a second edition. It's had made such a splash and was so well received that they asked us to come up with a second edition and kind of follow through. So it's kind of a nice compliment we got. Any other questions, Chris, before we transition?
I, I think we've covered most of the ones that came in before and during the webinar, so I think we're good on the pituitary. Any from the audience that you want to ask? All right. If they come along, please put them in the chat or raise your hand and we'll try to get to them at the end if we have time.
Is there a couple things in the chat there, Chris, now? Take a quick
I
peek.
think we did all those.
Okay, all right, sounds good. Okay, so let's move along. I'm going to go to the next thing. I'll just briefing and introduce this topic. We'll switch over to meningiomas. I'll introduce a couple of things, and I'd like to turn it over to Chris because he's got some great things to share as well, and then we'll look at our timing on the clock for acoustic neuromas. Meningiomas are these tumors that grow from the lining of the brain, anywhere from down the middle here in the falx, or anywhere on the surface, or anywhere on the bottom of the brain, which we'll talk about why that's a particular challenge. On this cartoon here, you can see this is a meningioma kind of pressing, starts from the lining and then pushes, almost like putting your fist into jello kind of thing. They grow from these cells that are in the dura. They're pretty common. They make up, and it's always some debate, plus or minus, but about 40% of primary brain tumors are pretty common. There were about 42,000 patients diagnosed with meningiomas in the last year. And the peak is this 40 to 70 year, although they do happen in children, they happen in older individuals too. But that's sort of the peak of incidence, it's believed. The World Health Organization has a grading system for meningiomas. The vast majority are quote unquote benign or low grade, fortunately. There is a grade 2 called atypical, where these are basically tumors that are kind of in between that tend to grow back. We tend to be, or we try to be more aggressive getting them out and try to get every cell out. They often tend to require some form of radiation, either upfront or down the line. So a little bit of a different animal than grade 1. And then grade 3 is a totally different thing, where this is a cancer. This is an aggressive, it's called an anaplastic variant. This is a real carcinoma or sarcoma kind of a mass. Unfortunately, these are rare. They occur in certain ages, and they can occur in almost any age, but there's certain profiles for them, but much, much less common, but much more aggressive. Again, they can occur anywhere along the surface of the brain. You can see some here, like this is called convexity, near the midline called parasagittal, along the falx, and then all along the cranial base, what Chris and I specialize in. We spent years training to do this, both in residency and fellowship, years honing our skills here, where we work not only in surgery, but the things you don't see in our lab and in our anatomy lab and things like that. Training our fellows and residents and even ourselves in sharpening up our skills to work in these very challenging areas along the cranial base. The treatment options are, number one, observation. When these tumors are picked up incidentally by accident, someone has a headache or a bump on the head or gets a scan for some other reason, and lo and behold, there's a meningioma, we go down the observation pathway, the surveillance route. We'll typically check a new scan in 6 months. Maybe check another in a year, and then go annually for a while. And there's a pattern of following these tumors and keeping an eye for any growth, which is usually slow, maybe a millimeter or two a year on average, or any new swelling or any new symptoms that develop that may require us to go down one of these other pathways for treatment. Surgery is a mainstay for this. It's the oldest intervention for this, going back 100 some odd years. Which is basically to do a removal of some sort. I'll show a few different techniques for how we might do that, but surgical removal of the mass in any area of the case around the brain that it's attached to with a margin and try to clear it out. The greater the removal, the greater the margin, the less chance it's going to come back. Certainly we're constricted sometimes by critical structures it might be stuck to or encasing. And then radiation, form of ionizing radiation. This is just showing a type of a gamma knife system here. We've got a number of different devices we can do this with. But you can see the various beams all pointing at the tumor. And this has a very good track record for controlling the majority of meningiomas. Certainly those that are in the lowest grade has a very high track record of control, probably the mid-90s and sometimes higher. Craniotomy. So this is basically removing a window of bone to access a tumor. You'll see this tumor up in the little cartoon on the side. This is a yellow tumor kind of pushing in. It's got a little tail on either end, which you'd have to remove that tail as well as the mass. we need a craniotomy to get to it. The head's like your head is like a helmet or like a coconut, to get inside, you need to make a window. We have a host of different incisions we make for any place we're going to go to get into the skull. And once that incision's made, we need to make a craniotomy. That's basically removing a window of bone, almost like you might cut through drywall, where you can make some little pilot holes and then use a drill to kind of cut a piece of the bone away. And we'll set that aside in a sterile way. And then we have access to this tumor, either attached to the dura or below the dura, but this mass, like showing here, kind of sitting, denting in the brain. And so we have access to try to remove it. And this would depict something like a convexity meningioma. Cranial base is much more challenging. Where these tumors are located all along the base. Don't forget, looking at this picture, there's a brain sitting in here. Blood vessels, nerves, things we have to work around to get these very tight, difficult, and almost impossible to see areas to remove these tumors. And so this might require a craniotomy. Sometimes we've got to remove window of bone. Like in this case, this is the patient's orbits. This is an orbital osteotomy, removing a piece of bone to get down closer to the tumor and expose it. And you want to take this deep tumor and make it more of a superficial thing to access. But yet, even when we do all that, sometimes the tumor can be encased by all of these critical structures, blood vessels and optic nerves and things like that. Very challenging place to work. That's why, again, we've trained for so long to do it, and we train others to do it as well. And this would show the difference between a tumor at the convexity or near the surface, even if it's on the back near the surface, versus these that are all along the cranial base, places you can't really point to or touch or easily like you can on the surface. And so getting to these areas can be very, very challenging to get under the brain and under these different structures to reach these traditionally. And this is where endoscopy can play a great role. We can introduce an endoscope in the nose or mouth, and we can access, as you can see here, looking in different directions and using angled instruments, we can work all around the cranial base. And this is how Chris and I will approach these tumors to try to remove them and get access to decompress some of these structures. And they're all named for the location where they originate, but they're all slightly different. But then they take maybe different angles of approach and different instruments to remove them. Some advantages are we can come right at the tumor. We don't need to lift up the brain or work around these other structures. We can disrupt this blood supply very early on, which comes from the bottom. We have good removal of the dural origin. Remember, it's stuck on the dura. It's coming from the dura. We need to remove a margin as best we can. Just look down below a lot of these critical structures, so it can be helpful. And here's an example of endoscopic removal of a pretty good sized meningioma. You can see on these pictures on the left, and in the post-operative, you see this sort of a cavity where it was. But this didn't require craniotomy or any external incisions you might see. Doesn't require any brain retraction or manipulation of other structures. We can come sort of straight at it. So not all tumors can be removed that way, but when they're in the correct location and you have the right skill, you can take them out in this way. This is actually, this one here, yeah, is a smaller one. This is a 39-year-old. This is a model, a young woman who's a model, and she lost a sense of smell with this mass and was afraid about getting incisions on her face or head because of her career choice, and also was afraid of radiation because someone in the family had radiation previously and really wanted it out. And so this is a great choice for endoscopic removal. And you can see the post-op here with a nice removal of that mass and preservation of all the sinus structures, but a nice removal as well. Another example of a tuberculum cella meningioma sitting in this region that would affect the vision, the pituitary gland, etc. And we can do an endonasal removal of that. This is the kind of thing we studied. Chris and I worked on this series of patients to study these types of tumors and the merits of doing them endoscopically as opposed to through craniotomy. And we found that we get an equal removal statistically. We have better visual outcomes endoscopically and very low side effects. And so this was very reinforcing for endoscopic when the tumors are selected correctly. So I'm going to turn it to Chris. I feel like I've been hogging the day, and I didn't mean to, Chris. I guess it just started out. But I'm going to turn it over to Chris with kind of what's new, what else are we doing with meningiomas, et cetera, and to talk a bit about acoustic neuromas, time permitting. So Chris, please go ahead.
Yep. All right. Thanks, Jim. And, we obviously want to be conscious of the time here and not run too long. So I'm going to sort of rush through a little bit of stuff and hopefully share some exciting things. I'm going to share my screen.
Okay, yep, you're up, Chris. Let's go to the.
You see the correct one?
You're in the presenter mode, and we see the one on the side there.
All right.
Now you're good. Yep.
All right. So just to continue along with meningioma. So As Jim said, the meningiomas are overall the most common type of brain tumor there is. You can see it making up about a third of all different types of brain tumors. They can occur, as you said, anywhere along the brain. They can either sort of be relatively straightforward, like this small one on the surface, or they can be very complex along the base of the skull. Patients always ask, where did this meningioma come from? Did I do something that made that form? When we look at what's called the epidemiology, or all the data about why things form, we see that meningiomas, women are twice as likely as men to have these types of tumors. And we think that's because the meningiomas on their surface have estrogen and progesterone receptors that sort of feed the tumor and get them growing. Someone asked in the chat, what percentage have these? So about 70 to 80% have progesterone receptors, about 30% have estrogen. What's not so clear is, well, these hormones probably get the tumor growing. If you have excess amounts, like things like hormone replacement therapy, do they keep the tumor growing? Do they make it harder to treat? That's less clear. As we see these meningiomas, about half the patients I saw in the office today have what we call an incidental meningioma, where someone got an MRI for some reason and we pick these up. These things are very common. As people get older, as you can see, this is women and this is men. As we get older, these things are more likely to form. Eventually, we sort of stop looking for them, but it's not very uncommon to find these things, and many of them never require any treatment. So what causes them? Most of the time, it's some mutation in the DNA that gets one of these cells in the covering of the brain, the meninges, growing. Most of the time, we don't have a clear answer. We do know there are some risk factors. So there are definitely some patients with genetic risk factors, or something called neurofibromatosis type 2, where people are born with a mutation in every one of their cells in what's called the NF2 gene. If you have that, there's a very good chance you're going to form meningiomas over your life, as well as other types of tumors like acoustic neuromas, these benign types of tumors. While most patients don't have that, they're not born with that mutation, somewhere along the line, one of these cells picks up that mutation. And this is the most common mutation we find when we study these tumors. We know that what's called ionizing radiation can lead to tumor formation, not just meningiomas, any tumor in the body. If you're exposed to radiation, it can mutate the DNA in the cells and cause them to grow. This is sort of the electromagnetic spectrum of radiation. Those ionizing radiation areas are way here to the right, things like the sun, which is weak, things like gamma X-rays, and here these are much stronger and can mutate the DNA. People always ask me, what about cell phones? Can that cause it? That's way down here on the spectrum, does not have enough energy to mutate the DNA, so we don't think that can cause it. But jury is still not fully out on that. I said that radiation, we know that can form these tumors. There were, sad examples of medicine gone awry in the past. These were kids that had ringworm on their scalps. People used to cure the ringworm by radiating it. All these kids with the white stocking caps, they lost their hair from radiation to treat ringworm. And this is what happened to them 30 years later. They formed all these meningiomas, many of them very aggressive, growing through the skin. So, we've made some mistakes along the way, but we've also learned about what can lead to some of these tumors. In terms of the natural history, basically a lot of these tumors we pick up on MRI. Over the years, they're becoming more common. That's because people are getting, not necessarily because there are more of these meningiomas, we're picking them up more on MRI. When we find a meningioma, we don't always rush to treat it. Some of them we need to treat. They're huge. They're causing problems, but many of them we're going to watch. We always say the average meningioma grows 1 to 2 millimeters a year, but that's the average. That doesn't mean your individual meningioma will grow 1 to 2 millimeters. Some of them, this is a growth rate. Some of them never grow, or grow so minimally over decades that we never need to do anything. Some of them grow very fast. These are the ones we never want to miss. So this is why we always encourage a follow-up scan, when we're very conscious at figuring out how each individual tumor is growing. But we tailor our follow-up, our treatments to each individual patient.
And Chris, there was a question that popped up when I saw that about, do some of these tumors grow rapidly, or can they? Like, I'm assuming they were asking like under what circumstance.
Yeah, yeah, and it's, so this ties in a little of this slide where not all meningiomas are created equally, in terms of where they're located or in how fast they grow. Um, most of the tumors are what we call this benign or grade 1. They're about 2/3. Those tend to be that slow 1 to 2 millimeter growth rate. The atypical or the malignant grow much faster, and they're much harder to treat. Fortunately, those are not the majority, but we always want to pick those up, and we need, as surgeons, if the tumor is more aggressive, we need to be more aggressive. So figuring out which tumors are going to grow fast and which are going to grow slow is a lot of what we do as brain tumor surgeons. And we'll talk a little bit about some of the exciting things we do there. The other thing we know is that most people tend to think, we titled this benign tumors, and we put it in quotes because they're not all benign. They can come back, they can cause lifelong problems, as many of the people on this webinar can probably attest to. This is sort of this is a great day in our world. This is a fairly small meningioma. We go in, we pluck it out, we cut some of that meninges around, we take a margin. This patient is probably going to be cured if it's the standard meningioma. And we've known this for 70 years. If you go in, this was a Dr. Simpson that looked at all of his tumors, and he said, if I go in and remove every last bit of it and I take a margin, 90% of these are cured. They'll never come back. But there are some, even with that surgery, that can come back because there's little microscopic cells. In some cases, like this tumor, where it started here, but then it grew down. It actually grew out of the skull, below the jawbone, and outside of the brain. This is going to be really hard to get every last cell. And this is probably one of those more aggressive tumors. And if you don't get every last bit of that, that's going to come back, around a 50% chance that will come back. So again, not all of them are created equally in terms of where they're located or how complex, and neither are they in terms of their genetics and how aggressive they are. Somebody asked before the webinar, how come there aren't more resources for these benign types of tumors? And that there really is a disparity. We've got, for the malignant cancerous things, we've got things like the National Cancer Institute that fund billions of dollars to study cancer. When we apply for these grants, they say pituitary tumors, meningiomas, those are benign. And we really rely on philanthropy, small organizations like Meningioma Mamas, patients who've had these tumors and realize these aren't necessarily benign. They can cause big problems, and they funded a lot of our research. Fortunately, the cost of doing some of this research has gone down dramatically. This was what's called the National Cancer Institute's Human Genome Program, where they set out in year 2000 to study the DNA of the entire cell and sequence it. That cost about $100 million when they started. Now you can sign up for 23andMe for $200 on Mother's Day special. You can get your genome sequenced. That's the progress we've made in 20 years of studying the DNA. And now we can do this on all of these tumors and figure out what's different in each individual tumor. And that's really changed the way we study these. And
Chris,
a lot of
just one comment is that the other thing to bear in mind is some of these pathologies, we're talking about benign and malignant and things like that, some of these also occur in much younger individuals. And so you look at the impact of an individual's life that can be devastated by whatever it is, a pituitary tumor, an acoustic neuroma, a meningioma, or something where we can make such a big impact up front with good treatment, good surgery, et cetera, and get a good amount of longevity as well, versus someone that could be maybe really injured by a tumor like this if it's not managed well, or if it gets ahead and progresses too much before we get a chance to treat it. That can have a long impact for decades on that individual and their family. So just something else to bear in mind.
Yeah. And, so when we see a patient in the office, we often have to, they ask, what are we going to do? And it's always a group decision, but some of this is about predicting the future. How is this thing going to behave? What do we need to do to get it under control? And when you look at these 4 different types of tumors, they could all behave very differently. This one here could be aggressive, and we need to get every last bit of it out. this really challenging one that's wrapped around the nerves, it may be incredibly slow growing. And if I can get it away from the brainstem and sort of preserve all these by leaving a little bit behind, I may never need to do anything. So a lot of our job, and I can attest, Jim Evans is a very smart person. I think I've studied this for a long time. We have a generally good sense of how things are going to behave, but we're tricked sometimes. So how do we get better? Is it the size of the tumor? Is it the age of the patient? Is it the location? Is it because they had exposure to things like radiation? I'd love to know the genetics just by staring at the MRI, but right now the only way I can do that is by taking a piece of it, and that may help us. So we treat hundreds and hundreds of these tumors, and we thought, how can we learn from our experience in a better way? And there's a lot of emphasis on artificial intelligence. The idea that sort of the computer can and the robots can see things that the human mind missed, trends, patterns. So we basically took all of our meningiomas that we had removed. We knew what their genetics was. We knew what their percentage of dividing cells. We know how it behaved over times. And we put them into these models, and we worked with some really smart computer scientists. And it turns out we can be pretty good, about 85% effective at predicting how a meningioma is going to grow, if it's going to be faster or slower. This is incredibly labor intensive right now. It takes hours and hours per tumor to do this. But just like that Human Genome Project, the cost went down. We are going to get better. And when you see us in the office in a couple of years, there's no doubt that the computer is going to give me a model of how this tumor would behave and what might be the best treatment for it. It's not going to be perfect. You look at things, machine learning, artificial intelligence, it still has trouble differentiating a Chihuahua from a blueberry muffin, or this dog from a mop. So it is not perfect, and we need to be aware of that. But it is the future, and it is the now. It's common these days to use this type of things for chest X-rays. They're probably better than our radiologists at detecting pneumonia and other things, and it's going to get there for brain tumors. Just a little bit of a case example. This was a patient that was sent to me for this tumor. They'd already been operated on an outside hospital. This doesn't look bad. There's the tumor. There's a little bit of what we call a tail. And when you look at it, you say, okay, this is simple. Go in and cut it out. There's the tumor, cut it out. We try to get that margin. But right here is a vein, a very important vein that you can't injure. And the doctors were sort of conservative and stopped here. The pathology turned out to be that aggressive meningioma. And the next scan, here are all the tumors gone there, but now it's growing along that vein and down what's called the falx that separates. We've got a big problem now. Now this is going to be very hard to cure surgically. I still can't injure that vein. I can remove some of that, but there's going to be tumor left behind. Fortunately, we have learned over the years that we can treat these with aggressive radiation, either focused or larger field, and most of the time these tumors will get under control. So it's pretty rare these days that we lose control of a meningioma, but when we do, what are we doing about that? Everybody asks, can I take a medication? Is there anything I can do for that? Right now, I would say no, but we're getting dramatically better. We used to try different medications for any meningioma and say, okay, it only worked in 5% of the time. Well, now we're saying, why did it work in those 5%? Let's look at the genetics. Let's go back and figure it out. Let's see that pattern. And we can individually sequence the DNA of every one of these tumors if we need to, and make an educated guess of what the best thing for that individual tumor will be. That doesn't mean it's going to work, but we're not just throwing darts. We're trying to do this in a strategic and a smart way. And this has worked for the majority. There's probably, again, patients on this webinar who've had tumors get out of control, but overall we're doing pretty well, but we're striving to get better every day. And we thank all of you for your support and for coming to Jefferson, because I think you're helping patients down the road with many of your commitment to participating in these studies that we do. And we try to collect every single tumor so we can study it, and as advances come on, learn about those. I think we can probably stop and not go on to the acoustic neuromas in the interest of time here.
I apologize to whoever asked that question. There's so much to talk. We're so passionate about this, and I'm hoping we'll be able to do this again down the line. And we'll be happy to address these other topics. We could go on and on for hours. Like I said, we study and we've learned so much over the years. We love to share it. There were just a couple of questions I'll try to field that came up. One was, does gamma knife cause meningiomas? And really where we see that is with Chris showed you some various examples of ionizing radiation and external sources of radiation that are larger fields. Usually when we're giving stereotactic radiation, it's such a pinpoint, it's so honed in area that it's much less common. Can it? Yes, any radiation can eventually cause a meningioma to grow, but it's much less common with very stereotactic and conformed treatments. Another question that came up was proton beam versus photon therapy. So traditional focused radiation is photon types. So proton is basically a heavy particle radiation. It's a big particle radiation that's delivered, and it takes advantage of the fact that it can slow down the particle and stop before a critical structure and build up a big dose called a Bragg peak, with very little, if any, exit dose. Now, a couple of things to bear in mind. Photons are not magical. I mean, proton beam is not magical. And this has been around for ages. It's just another way of delivering a heavy particle. There's lots of different ways of radiation. This is just one of them. The second thing is that it's just a form of radiation, although it has slight different properties because it's a larger particle. It's not magical in some way, although it can take advantage of not stopping at a certain depth and not having the exit dose from the proton beam part of it. But the other thing is that many of these treatments are given as a combination. And in some cases, treatment is actually photons. In some smaller portion is a heavy particle proton. It turns out photons or protons, if you can deliver the same amount of energy safely, it doesn't matter how you give it. They're just different ways. Like you might drive a Chevy to work and I drive a Ford, but they both get us there. It's just taking advantage of difficulties and finding a way to get the adequate dose and safely. The other part of the question was, is this coming to Jefferson? Yes. In fact, we have a proton beam that we've been working on logistics of where and how to construct it. But yes, we will have proton therapy here. But as I said, still not a panacea. You still need to have the myriad of devices, whether it's a gamma knife or a accelerator or a tomotherapy or a ZAP device or a proton beam. You need to have the myriad. That's what we try to really have in our radiation center here, is to be able to offer all of the different tools, because they each have their own utility depending on tumor type and location. And one of the last questions I talked about very quickly is, how do you donate? I can't ask about a more poignant, I mean, I couldn't address a more poignant question. Thank you, whoever said that, and we appreciate that. That is literally how we survive day to day and week to week, is with patients being generous enough to help and donate and keep the cause going forward. And also in donating their time, also in donating their tumor tissue sometimes to our tumor bank. Most every patient has agreed to do that over time, and it allows us the material study that we may be able to help others in some generation down the line. There are ways to do this. You can contact us directly, or our Office of Institutional Advancement, or OIA. We can provide that to you either at this webinar or the next, or we can send that information out. But we can't tell you how grateful we are to people like you that donate and help us to keep moving, keep the lights on, because we're so invested in making a difference, and that's how we do it often. But thank you so much for everyone for joining us. Chris, any last comments?
Yeah, I mean, I apologize we didn't get to every question, and I apologize that we didn't cover all the tumors. I think we're always, our eyes are, we think we can get through more things, but I think this was great. Thank you all for coming. Thank you for asking such great questions. Hopefully you got something out of this. I'll ask the organizers if there's extra time to add on another webinar to do the acoustic neuromas, or we can, we'll be back, and we're always here for you if you need us. So
we enjoy this, and hopefully as much as you guys do. So thank you all for coming out. And Sean, thank you for helping run things tonight.